Thank you and welcome everyone. I'm so excited that you decided to tune in with me today, just basically to review the newest addition to our profiles at Genova Diagnostics. It's called the Cardio Check. Here's my picture, a little bit about me. I received my doctorate of naturopathic medicine from the Southwest College of Naturopathic Medicine, followed by a master's of public health from the University of Alabama at Birmingham, and I've been with Genova since 2014, serving as a medical education specialist in the Department of Medical Affairs. Before we begin, there's two important housekeeping notes that I'd like to highlight. Number one, if you have any questions or even technical issues, please type them into either the chat or the questions box, making sure to send them to the organizer at any time during the webinar. And number two is the presentation is actually available right now for you to download, and you can access it under the Handouts tab. Just simply click the link and the download process will begin. In addition, you will have access to the presentation, the slide deck on our website within a few days after the webinar, and you can access these resources, previous webinar recordings, brief video modules, and just a bunch of other really cool materials by clicking on the Clinicians tab on the homepage. We still do offer patient dropship options for our virtual patients, and we also now offer online scheduling. If you would like to talk to a medical education specialist, just go ahead and log into your MyGDX account for more information. Again, for today, we're just going to review the newest addition to the Genova profiles, the Cardio Check, which is an advanced assessment of cardiovascular and metabolic risk. So here's what we have on the agenda. We're going to review what is known and understood about atherosclerosis. We're going to do a very deep dive into the various components of the Cardio Check profile and discuss the various modifiable risk factors for cardiovascular disease. So this is what we know and understand about atherosclerosis. We know it starts in childhood and progresses over the years, manifesting later in life. Plaques are mainly made up of cholesterol, and they can build up in the arteries, leading to narrowing of the blood vessels, which will reduce blood flow. If the vessel is completely blocked or the plaque dislodges, it can lead to cell and or tissue death. So let's just kind of go a little bit backwards. Let's look at the history of atherosclerosis and how do we know what we know today. So interestingly enough, the initiating events of atherosclerosis or plaque formation, it's been widely debated until about 2017, where we began to link inflammation to atherosclerosis. And although we have proof of plaque formation as far back as ancient populations from Iceland and Egyptians, some 5,000 years ago from scans performed on mummies, it wasn't until lifestyle changes that occurred with industrialization that we started to notice atherosclerosis and cardiovascular disease present all over the world, regardless of race, culture, or ethnic groups. So this shows us that it isn't a disease of modernization, although mortality has increased. Around the mid-19th century, the idea of inflammation as a cause of atherosclerosis emerged, but many were divided as to whether inflammation was an initiating cause or a sequelae of plaque formation. Jumping over several years, which we'll go back in just a bit and review the early 20th century discoveries. Jumping over several years, this brings us to 1993, Mr. Russell Ross, who proposed this very interesting hypothesis called the response to injury hypothesis, which basically stated that the initial event in the pathogenesis of atherosclerosis is actually injury to the endothelium. Unfortunately, it's not until more recently that we as a medical community began to widely accept this idea. And when we look at the causes, we see oxidative stress, inflammation, hypertension, insulin resistance, and sedentary activities like sleeping, lying, and resting as all basically sources of endothelial dysfunction. So atherosclerosis formation happens as such. When you have the damage to the endothelial layer of the arteries, which we sometimes refer to as vascular permeability, It causes mainly monocytes, which are immune cells, to migrate to the area, squeeze into the intima using protein adhesion molecules, eventually resulting in plaque formation. So here we can see a detailed diagram of this process. The first few steps show the result of endothelial dysfunction or vascular permeability, allowing mainly your monocytes to squeeze into the intima using these protein adhesion molecules, and this is called diapedesis, and we see it here in step number 2 and 3. Then the macrophages, or the white blood cells, create free radicals within the intima, which then oxidizes LDL particles. And these oxidized LDL particles attract more white blood cells, which then produces even more radicals, oxidizing more LDL particles, and eventually forms these fluffy cells that we tend to call foam cells that you see here in step number 6. Note that the smooth muscle cells can also consume these oxidized LDL particles after the foam cell dies. Then the oxidized LDL particles that was engulfed is now released along with other particle fragments, and it forms this plaque covered by your endothelial cells, and it begins to harden through calcium and other factors, and it develops this necrotic core that we see here through shown in steps 7 through 10. This really speaks to the importance of inflammation, a potential endothelial dysfunction cause, and the role of immunity in the pathogenesis of atherosclerosis. So there are many consequences of atherosclerosis, such as heart disease, stroke, or coronary artery disease. But what stands out to me is that the leading cause of death in 2019, when we look at that chart, the top 3 are consequences of atherosclerosis. And number 9 and 10 on the list can actually be sources for endothelial dysfunction leading to atherosclerosis. So what causes atherosclerosis is kind of like the big next question. Honestly, there still are many theories. We just covered the response to injury theory, but what about cholesterol and its role with atherosclerosis? For this, we actually have to go back to the early 20th century. This is where we started to look at the role of cholesterol in atherogenesis, and it also led to the production of many medications focused on cholesterol management to help reduce the formation and the progress of atherosclerosis. These developments tended to minimize the role of inflammation, though, and other causes of endothelial dysfunction. So published in 1999 in the New England Journal of Medicine, it states this: thus, although hypercholesterolemia is important in approximately 50% of patients with cardiovascular disease, other factors need to be taken into consideration. Atherosclerosis is clearly an inflammatory disease and does not result simply from the accumulation of lipids. So this article is now directing us to not only look at cholesterol, but also other factors that can lead to endothelial dysfunction, like inflammation. And so, as many of you are aware, most clinicians still only look at cholesterol to assess a patient's cardiovascular risk. But what about the other 50% of patients with cardiovascular disease? Like this article states, who have disease but normal cholesterol levels. So again, we have to consider additional testing beyond our standard lipid panels, where we look at LDL, HDL, total cholesterol, and triglycerides. What about those factors that contribute to endothelial dysfunction we just reviewed, such as inflammation, oxidative stress, even insulin management? So, introducing the CardioCheck profile. It not only looks at the standard lipid markers, but we incorporated other markers dealing with inflammation, oxidative stress, and insulin resistance, or markers informing us about endothelial dysfunction. This way we can capture beyond the 50% of people who have cardiovascular disease or risk factors by looking at novel biomarkers beyond cholesterol. And the really nice thing is that many of these markers are modifiable, meaning that with lifestyle and diet modifications, yes, sometimes even medications, we can actually impact them. So let's look at the components of the cardio-check profile, starting with lipids, or the standard cholesterol markers, and some fascinating ratios. So LDL cholesterol, or low-density lipoprotein cholesterol, also considered our bad cholesterol because it actually can deposit in plaques and arteries when oxidized, leading to atherosclerosis, as we saw in the prior diagram. This is what many cardiovascular agents are targeted toward lowering when high, especially from the research done in the early 20th century, linking high LDLs to atherosclerosis and ultimately conditions like coronary artery disease, stroke, and peripheral artery disease. Some contributing risk factors to consider are genetics, diet, stress, sedentary lifestyle, medications, and disorders such as hypothyroidism. Another therapeutic strategy we can consider is not only decrease when elevated LDL-C, but also minimize the oxidation of the LDLs. And this can be achieved by the body's antioxidant defense enzymes, including superoxide dismutase, catalase, glutathione peroxidase, as well as using supplements such as vitamin C, vitamin E, ubiquinol or CoQ10, and other beautiful antioxidants. So the opposite to LDL cholesterol is HDL cholesterol because it carries LDL cholesterol away from arteries back to the liver to be excreted as bile, which is why HDL is often referred to as your good cholesterol due to the protective effects against cardiovascular disease. In addition, it has antioxidant properties to prevent the oxidation of LDL cholesterol, which again contributes to atherosclerosis. So low levels of HDL cholesterol can increase your risk of atherosclerotic cardiovascular disease when LDL is high especially. However, clinical trials really targeting how to increase HDL levels, it just hasn't panned out very well. The major treatment strategies we typically use are to normalize LDL levels and support HDL functionally using diet, exercise, as well as lifestyle modifications. Triglycerides are the most common type of fat in the body and act as a storage for excess energy derived from the diet. As a medical community, we accept that triglycerides are an independent marker for cardiovascular and atherosclerotic disease, but in addition, it contributes to the diagnostic criteria for metabolic syndrome along with HDL, meaning it has this potential link to insulin resistance or basically another cause of endothelial dysfunction. Total cholesterol, or TC, includes LDLs, VLDLs, and HDLs, cholesterol, and it correlates with atherosclerotic cardiovascular disease, plus it's associated with an elevated BMI, which many consider to have an inflammatory impact on the body, and smoking, which can lead to increased oxidative stress. Again, contributing factors to the start of atherosclerotic formation. Multiple epidemiological studies have shown that lipoprotein ratios have a greater correlation with cardiovascular disease and are a better predictor than the individual lipid markers themselves. So let's go ahead and look at triglycerides to HDL cholesterol ratio. It's shown to predict metabolic and cardiovascular risk. It positively correlates with HOMA or HOMA-IR and serum insulin after an oral glucose tolerance test. The other ratio is total cholesterol to HDL cholesterol. Total cholesterol elevation is associated with cardiovascular disease, and HDL is associated with cardiovascular protection. Therefore, a higher ratio reflects a greater risk for coronary heart disease. A ratio above 5 correlates with roughly 66% increased risk, while a ratio above 6 correlates with greater than 2 times the risk for coronary heart disease. As mentioned earlier, the good news is that with many of these markers, they're actually modifiable. Again, it can be impacted by lifestyle and dietary modifications, and again, sometimes even medications. So an ideal cardiovascular health diet is going to include many different factors. You have reduction in high glycemic foods, which includes a dramatic reduction in refined carbohydrates, your sugary foods, the sweets, the sweetened beverages, even starchy vegetables such as white potatoes. Incorporation of whole foods, focusing on items such as fruits, vegetables, whole grains, nuts, legumes, even your healthy fats and protein. Ensuring adequate dietary fiber intake to help in not only regulation of blood glucose, but also in the support of the microbiome, and it can lower cholesterol. Sources of fiber can include things like whole grains, nuts and seeds, legumes, and even some fruits and vegetables. Balance the fats. So if you look at your traditional standard American diet, it's often rich in more of your inflammatory fats that can promote cardiovascular risk. And that would be things like your hydrogenated oils, your trans fats, such as those found in fried and or processed foods. Furthermore, there has been a shift in our consumption of omega-6s and omega-3s. So swapping out these fats for more cardioprotective fats are recommended. So looking at more oily fish, olive, nuts, and seeds. Whenever needed, we want to make sure we adjust for calorie requirements, personal and cultural food preferences, nutritional therapy for other medical conditions, for example, diabetes. Specific nutrient insufficiencies have also been associated with abnormal lipid profiles. We look at zinc, for example. Zinc supplementation has been shown to reduce total cholesterol, LDL cholesterol, and triglycerides. In non-healthy patients, zinc supplementation increased levels of HDL cholesterol as well. We can look at supplementation with CoQ10, amino acids, magnesium, vitamin C, which also have shown promise as adjunct therapeutic strategies to optimize lipid profiles and important cardiovascular risks. When it comes to activity, we really think about aerobic physical activity, about 3 to 4 sessions per week, lasting about 40 minutes per session, involving kind of like your moderate to vigorous intensity. Weight loss, if appropriate, to achieve a healthy BMI, smoking cessation, and the HPA axis balance or stress management. So there actually is a really interesting abundance of literature examining the effect of both acute and chronic stress in the development of cardiovascular disease. So personalized interventions to manage stress and HPA axis function can actually help to lower the deleterious impact of stress on cardiovascular health. Moving to the lipoproteins. These are more advanced cardiovascular assessment markers to help us in identifying those patients that have cardiovascular risk factors or disease that also might potentially have a normal cholesterol panel. So apolipoproteins are surface proteins that recognize specific receptors on cell membranes, thus helping to determine fat distribution throughout your body. So Apo A-1 that we see here on the right-hand side is the main structural component of HDL, and so it assists in reverse cholesterol transport so we can excrete it from the body. When we're deficient in Apo A-1, we also tend to see HDL deficiencies. Remember, that's what we call the good cholesterol. Apo B that we see here on the left is the main component of atherogenic lipoprotein particles like LDL-C. There's one Apo B per atherogenic lipoprotein particle. Therefore, Apo B is like an indirect assessment of LDL particle number. So again, here we see Apo A-1 has those protective anti-atherogenic effects because it basically supports the clearance of cholesterol as a structural component of HDL cholesterol. When we review HDL, we spoke about its antioxidant properties to prevent the oxidation of LDL cholesterol, which we know contributes to atherosclerosis. Apo A-1 can actually modulate also inflammation and the immune response, which are both contributing factors to atherosclerosis. Therefore, with low Apo A-1, we see an increased cardiovascular disease risk. And important factors that lower Apo A-1 are diets that are high in trans fats, polyunsaturated fatty acids, smoking, and certain medications. We also tend to see lower levels with those who have uncontrolled diabetes as well as kidney disease. ApoB, the main component of atherogenic lipoprotein particles, and is a strong indicator of atherogenicity compared to LDL-C alone. Elevations are associated with atherosclerosis, cardiovascular disease, type 2 diabetes or insulin resistance, hypothyroidism, as well as certain medications like hormones. And foods that can contribute to an elevation in ApoB are trans fatty acids, as well as your saturated fats. Regarding the ratio of ApoB to Apo A-1, we prefer to see a lower ratio, which would indicate robust Apo A-1 and lower ApoB. This is more protective against cardiovascular disease. However, a higher ratio has a high predictability for cardiovascular disease and other conditions that actually involve insulin resistance as well as obesity. As with the other lipid markers, Apo A1 and ApoB are both modifiable risk factors for cardiovascular disease. So the same interventions we reviewed for lipids applies here. As a reminder, we focused on several categories: diet or reducing foods that convert into sugar, increasing your whole foods, fiber, healthy fats, regular physical activity, weight loss if appropriate to achieve a healthy BMI, smoking cessation, and HPA axis balance, as well as stress management. The last lipoprotein is LP little a or LPA, which looks like an LDL molecule, except it has an added protein attachment called Apolipoprotein A that you see on the right-hand side of the diagram. Like LDL, which is a cholesterol-rich lipoprotein, LP little a can increase plaque formation in your arteries. The fact that we have the Apo A attached to the LDL, it gives it additional qualities or properties, making it more atherogenic. So in essence, it inhibits plasminogen activator inhibitor 1, leading to decreased ability to disrupt or bust up clots. Plus, it has pro-inflammatory properties, only potentiating atherothrombosis. The combination of plaque formation, clotting, and inflammation definitely increases the risk for heart attacks as well as strokes. What's very unique about Lp(a) is that unlike your other cardiac risk factors, Lp(a), it cannot be modified by diet or exercise. So this is actually a genetically predetermined marker by the LPA gene. It can fluctuate at menopause and with kidney disease because basically your kidneys are responsible for Lp(a) clearance, but for the most part, it's pretty non-modifiable. There's some evidence about carnitine, coenzyme Q10, red yeast rice potentially decreasing Lp(a), as well as ginkgo or curcuminoids. However, the clinical benefit proves to be quite minimal. The last portion of the profile focuses on independent risk factors that may contribute to inflammation and disturbances in the methylation pathway, again, contributing to endothelial dysfunction or atherosclerosis, eventually cardiovascular disease. So there is a difference between CRP or C-reactive protein and hsCRP. CRP is non-specific inflammatory indicator that can be elevated due to inflammation stemming from infections, inflammatory disorders, endocarditis. However, we're measuring HS or high sensitivity CRP, which is more specific for cardiovascular related conditions like atherosclerosis. And this protein, as with many, are produced mainly in the liver, and elevations strongly correlate with atherosclerosis, subsequent adverse cardiovascular events, and death. Insulin resistance and diabetes, obesity, smoking, and medications like oral estrogens. We tend to like patients HSCRP at values less than 1. As with the lipids, it is fortunately another modifiable marker for cardiovascular disease. And so consuming more of a Mediterranean Paleolithic diet, as with elevated lipids, may be associated with lower levels of inflammation, including lower hsCRP and decreased oxidative stress. Lifestyle goals are to maintain a healthy weight, smoking cessation, and medications like aspirin have been shown to even be helpful in lowering hsCRP as well. Homocysteine, which we often link to methylation, is a risk factor for cardiovascular disease because this molecule is actually toxic to your endothelium, and it encourages thrombus formation and decreases nitric oxide, which is normally relaxing to vessels. And these are all factors that can contribute to atherosclerosis, coronary vascular disease. We also see when homocysteine is elevated, we have an increase in cell proliferation, platelet aggregation, or thrombosis formation. The mechanism is thought to be related to SAH or S-adenosyl homocysteine elevation. Again, another modifiable risk factor is an elevation in homocysteine. So looking at the diagram, you can see that SAH, the precursor to homocysteine, and the ability for the two to interconvert, only potentiating cardiovascular risk. So there's many nutrients that we can use to help normalize homocysteine as well as SAH, such as your B vitamins, especially B3, to help convert SAH into homocysteine. We think about supporting the folate cycle using B2, B3, as well as B9 and B12. Minerals such as iron, you'll see as a cofactor for a few different enzymes. Even using choline or betaine, promoting the backup pathway to convert homocysteine into methionine can be helpful. And when low, you also can consider SAMe, which is like a universal methyl donor that can help support these pathways. Well, there you have it. This is the cardio check profile. So we assess conventional biomarkers like cholesterol that contribute to atherosclerosis and novel biomarkers that contribute to endothelial dysfunction and are independent risk factors of cardiovascular disease. So basically, by combining the best of both conventional and novel biomarkers, it offers a broader look at cardiometabolic health to guide therapeutic strategies, and hopefully it helps us to identify those patients with normal cholesterol levels who still have a cardiovascular risk factor. So let's go ahead and address a few questions. So let me see here. The first question, if you could please review the causes of endothelial dysfunction. Sure. Oxidative stress, inflammation, hypertension, insulin resistance, and being sedentary. Those are the causes of endothelial dysfunction, which is thought to be the initiating step to atherosclerosis formation. Another question here, markers on the cardio check that informs us about insulin resistance. Okay, so high triglyceride to HDL ratio, remember that positively correlates with HOMA-IR and serum insulin after an oral glucose tolerance test. Elevated hsCRP also correlates with insulin resistance and diabetes. ApoB elevation but also the elevation in the Apo B to Apo A-1 ratio has a high predictability also for insulin resistance and diabetes. Markers that may elevate with oxidative stress. Okay, so markers that we look at that can be high with oxidative stress are things like your Lp(a), your hCRP, and homocysteine. I don't think I really reviewed very well this relationship between homocysteine and oxidative stress, so let me go into it. So when homocysteine goes into transsulfuration, or an irreversible pathway to clear homocysteine, it'll either feed into the citric acid cycle for energy or ATP production, or it can contribute to glutathione production. So if homocysteine is elevated, we may not have the proper precursor, mainly B6, to convert it eventually into glutathione, which again has antioxidant properties. A protective marker actually against oxidative stress, especially to LDL cholesterol, is Apo A-1, because again, it decreases oxidation of LDLs, which eventually creates plaque formation. So let's go ahead and answer the question and answer period there. For additional education materials, we'd like to encourage you to visit our website, www.gdx.net, or please contact Client Services. We also offer complimentary appointments with our medical education specialists in answering questions related to our testing, including choosing the right test and reviewing patient test results. We'd like to encourage you to register for our upcoming webinars on www.gdx.net. Lastly, if you have not already, please check out the Genova Diagnostics podcast, The Lab Report, which is focused on functional and integrative medicines, specialty laboratory diagnostics, and natural therapeutics with hosts Dr. Patty and Michael, and assortment of guests as well. In fact, next month, don't miss it. You should check it out. Don't forget to register. We have some interesting topics coming up. Again, thanks for joining me as I reviewed the CardioCheck profile.